Hi, welcome to MD Newsline podcast. Thank you so much for joining us. Please introduce yourself to our audience.
I'm Dr. Michael Robers. I'm a multiple sclerosis specialist and neurologist and neuroimmunologist in Phoenix, Arizona at Barrow Neurological Institute.
Great. So, you gave a talk here at the conference about hypertension and its impact on multiple sclerosis and health disparity, but I'm so interested in finding out how you came to do this work in the first place.
Yeah, I've always been interested in health disparities even before I knew I wanted to go into neurology, actually. I view medicine as a service to the community, and one of the biggest concerns that we have in US healthcare is communities that aren't maintaining their optimal health and achieving their optimal health in part because of poor access to care or other social and structural factors that are then modifiable. And so that's always been an interest for me. And then specifically, when I became a neurologist, when I became involved in multiple sclerosis has known health disparities where not everyone with MS has the same disease course. And specifically in the United States, there is evidence to support that Black Americans, Hispanic Americans, and Indigenous Americans all have potentially worse outcomes than white Americans with MS. And that's not fully understood why. And so that's an area of research that I trained in and when I was at University of Southern California with Liliana Mesqua, who does a lot of Hispanic American research. And now that I'm back in Phoenix and at Barrow Neurological Institute, I'm trying to kind of expand the availability of that research to our local Phoenix community.
hmm So, when you say worse outcomes, are people who are a part of the African American population getting MS more often, or are they being diagnosed at later stages? What do the disparities kind of look like?
Yeah. So, when I say disparities, what I'm referring to is disability, and that can be measured in different ways. So, most commonly, it's talking about physical disability, like walking and things like that. But there's also evidence about increased cognitive difficulties, which we know many people with multiple sclerosis end up having cognitive difficulties, but that seems to occur faster and earlier in Black Americans who have MS. And the full reasons are not fully understood. Part of that might be underdiagnosis
Mm.
initially. So it used to be thought that multiple sclerosis was predominantly a quote unquote white person's disease. There are certain populations in Northern Europe and Scandinavia that have very high rates, and that's where that came from. But within the United States, everyone living with similar risk factors, most recent studies have actually indicated that. Black women and white women in the United States have very similar rates of multiple sclerosis, with some studies actually indicating that Black women had higher rates of multiple sclerosis than white women, even. Although looking at the large data, I'd say it's safest to say they're similar, but it's certainly not a white predominant disease. And so, if that is the case, then for years we've likely been underdiagnosing multiple sclerosis in minority populations. But there is also possibilities that despite equal diagnosis, if you diagnose people at the same time, that there's actually worse progression of the disease and inflammation. And that can be attributed to many different factors that are not fully understood yet.
Mhm. So, how do we get to hypertension as your main area of focus right now?
Yeah, so my interest in hypertension specifically started when I was in training at University of Southern California, and that was at a time where comorbidities were becoming a very high area of focus within the multiple sclerosis community, where some large cohort studies, meaning these large databases that were available in like Canada and nationalized healthcare or large insurance databases were indicating that people who had a diagnosis of multiple sclerosis and a diagnosis of a vascular comorbidity had worse disability than people who had multiple sclerosis alone. And that could include many things, whether it was smoking or high blood pressure, high cholesterol, diabetes, things like that across all of those had some of that evidence. And so we wanted to look at that specifically in Hispanic Americans. And this data got published in 2021 in Multiple Sclerosis Journal out of the USC in Los Angeles location of the ARMS registry. And what we looked at was overall disability levels that we measured as basically the need of using a walking assistant. So we were looking at physical disability, and we looked at all of those different diagnoses in people, Hispanic Americans with multiple sclerosis in the Los Angeles area. And what we found was that hypertension specifically was associated with worse ambulatory disability. About 2 times the odds of having to use a cane for individuals who had high blood pressure and MS, as opposed to the people who had MS but not high blood pressure. And we also looked at diabetes and high cholesterol and smoking, and those didn't have as strong of an association. So that's where kind of we focused in on hypertension. And one of the interesting findings of that paper was that we went back and looked at all of these individuals' actual blood pressure readings. So we didn't just look at whether or not they had a diagnosis of high blood pressure. We actually looked at what is their blood pressure right now. And we found two interesting things there. One, that the level of hypertension control seems to be a predictor of how disabled they were. So it wasn't just anyone with a diagnosis of hypertension, it was specifically the people with uncontrolled hypertension or stage 2 hypertension, which means systolic blood pressures over 140 or diastolic blood pressures over 90, that really drove those associations with over 3 times odds of having that ambulatory disability. And while we had that, we also looked at who could we diagnose with hypertension just by vital signs, like what was their actual blood pressure. And what we found was that when we looked at the diagnostic codes and or patient surveys, 7% of that population said, hey, I have hypertension, or their chart said, hey, this person has hypertension. When we looked at the vital signs, 27% of individuals actually had diagnostic vital signs of hypertension. So there seems to be this gap. And that's where my interest in hypertension awareness actually came in, of like, hey, if hypertension is treatable and hypertension is not being fully diagnosed in these individuals, that's very actionable. That's a care gap that is cheap and easy to say, hey, we need to diagnose more hypertension and treat more hypertension, and maybe we can actually intervene on some of this disability.
What is it about hypertension itself that makes it so impactful? Do we know anything about maybe
That's a phenomenal question, and the short answer is we don't know. I have multiple different hypotheses on this, and I think the overall hypothesis is, so one is it could just be that having two diseases is worse than having one disease, right? And there is some evidence that, where some of the previous data on comorbidities said the more comorbidities you have, the worse you do as well, and certain cutoffs that they did, if you have 3 or more or things like that. Um, and so it is possible that honestly, just this is a marker for people who are more sick. They have 2 diseases, they have 3 diseases instead of having 1 disease. And if you have 2 or 3 diseases, you do worse than if you only have 1 disease. And that kind of makes sense. But there is also a body of literature, especially within the hypertension literature outside of MS, that shows overlaps with MS. So we know that hypertension leads to arterial stiffening and fibrosis and things like that. And they now know that that process is inflammatory. And many of the pro inflammatory signals related to hypertension have evidence of pro inflammatory signals in MS. And I think there is a very real question about whether, and that's kind of true in diabetes, which is a pro-inflammatory, and metabolic syndrome is pro-inflammatory. And so I think there's a very real possibility that these comorbidities, including hypertension, are in fact pro-inflammatory and actually worsening the pathophysiology of multiple sclerosis, but that is not proven yet. And so we don't know.
so um I'm always talking about inflammation, which is it's not my special interest, but I was just talking to some dietitians from Australia, actually, and we started kind of talking about inflammation and anti-inflammatory diets later on in the conversation. This is something that we hear across specialties every time, from neurology to oncology. Like, there's always kind of this idea of, yes, and inflammation exists. I'm wondering, when I think about the future of medicine, especially like getting more precise and personalized, what I'm finding is with my conversations with doctors across specialties is that there isn't a lot of interspecialty conversation and connecting of the dots. And when we look at things like epigenetics, for instance, I'm thinking specifically when people take use machine learning to look at past clinical trials and past research and what have you, some of the insights that are being found are really building a picture of this multidimensional view of any one disease, right? Uh, so when it comes to collecting data and thinking about how that data might be used in the future to pick up some insights to help us better understand diseases, is that something that you're thinking about when you're collecting data? Is that a conversation that's being had in this world?
So I think there's a couple of things there. One, we always have to be thinking about how data might be used in the future, especially when we're doing prospective studies and you actually have to consent for whether or not you can use someone's data in a different way in the future and things like that. So people are trying to think of like, okay, how else can we use this data? Especially the more and more we get into quote unquote big data and AI and like how can we actually use these large databases to improve health and improve medicine. But I hear you, and I think that you're spot on in that there's not enough collaboration across specialties. Um, and there's a lot of reasons for that. When I was in medical school, a paper came out that actually just looked at the number of journal articles that were published in a year in medical journals, and then looked at the average time spent at work for a doctor, and they basically showed and I think they looked at the average reading speed as well, and they basically showed that it was impossible for any one doctor to keep up with all of the published medical literature, even if they did that as their entire full-time job and never saw a patient. They would not keep up with all of the medical literature, and so the result of that truth is that we're becoming more and more hyper specialized because while it's impossible for me to keep up with all of neurology, it is possible for me to keep up with neuroimmunology and multiple sclerosis. And so you get these more and more specialized people. But as I get into my individual research and looking at comorbidities and hypertension and health disparities, the more I joke, the more and more subspecialized in neurology I get, the closer I get to becoming a primary care doctor instead of a neurologist. And there is that overlap. And I think in the future, we'll have multiple hyper specialized individuals collaborating to recreate that generalized knowledge that we used to rely on.
Why do you say the more subspecialized you get, the closer you get to being a primary care doctor?
So it's a unique situation in multiple sclerosis because of the more in multiple sclerosis, it's a chronic disease that is treatable, and so we're seeing patients over years and decades. And when I went to medical school, being a primary care doctor was actually what I thought what I was going to do before I became a neurologist, and I just fell in love with neurology. But a lot of what I liked about primary care, you get in MS specialty care. I'm seeing people who are diagnosed young, and I'm talking to them about family planning and things like that in the setting of disease modifying therapies. And I'm seeing people who are older and going through retirement and talking about, okay, financial changes and going on to Medicare. What does that mean for your treatment? Or just age and the reduction in MS activity and discontinuation. How long do you have to be on treatment? How strong of treatment do you have to be on? Your risk of infections go up. And so I really do get that lifespan of care. So that's one thing that's just inherent in MS. But then specifically, kind of the more I get subspecialized into my niche of research, being kind of these health disparities potentially caused by comorbidities and the treatment of hypertension, that then has this huge crossover with primary care doctors and screening. And one of my big points that I made in my presentation yesterday is that we're looking at hypertension awareness. A lot of MS patients, just anecdotally, they just see their MS doctor and they don't necessarily get as cued into their primary care doctors that they have. And I don't know if this contributes to the findings that I have or not. We'll have to do more research to really look into that. But what we found was basically we looked at hypertension awareness, and hypertension awareness is someone who has high blood pressure. Are they aware that they have high blood pressure? Do they report they have high blood pressure? Do they take their medications for high blood pressure? Or do they not even know that they have high blood pressure? And basically what we found is that in a population of multiple sclerosis patients here in Phoenix, that over 50% of people who could be diagnosed with high blood pressure by vital signs had no evidence in the chart that they were diagnosed with high blood pressure. They weren't taking any high blood pressure medications. They appeared to be unaware that they met
Mm.
diagnostic criteria for high blood pressure. And interestingly enough, the people, when we looked at risk factors for hypertension unawareness, meaning that they didn't know they had high blood pressure, the risk factors for that, the associations for that, I should say, were women, young people, and people with less severe hypertension. So, less severe hypertension kind of makes sense. If you have a really big high blood pressure number that's going to catch everybody's eye, you're going to find out more. Whereas if it's borderline, some people might say, oh, maybe it's just a little stress of being in the doctor's office or things like that, but then they're consistently there. But there's a big gap in care there for the other two, right? There's no reason not to be diagnosing and catching women with high blood pressure in MS and young people, specifically, who maybe aren't going through all the screenings that they need to. My hypothesis, not proven in our work, are being missed, and so it might be an area where MS specialists, even though we're not primary care doctors, could play a significant role in improving the diagnosis of high blood pressure in patients with MS. And maybe we don't actually treat that or things, but we make sure that patients are aware and get them into primary care doctors, talk to them about the importance of their overall health, right? And I think that's becoming a big thing in MS too, is like, it's not just, yes, first step, you see me, we need to get you on a disease modifying therapy that's going to prevent disability, going to prevent inflammation. But then it's about all of your wellness and brain health and keeping as healthy as possible for 20, 30 years with this disease that are going to make a lifetime of difference. And so the more and more we get into subspecialty information about MS, the more and more we're like, it really is about all of these wellness things that primary care doctors have been looking at and talking about for decades.
Yeah, interesting. What are some of the other missed opportunities that you're finding? And when it comes to patient awareness or doctor awareness, is it because when someone is already diagnosed with MS, we're saying like this kind of full screening is not included in the package of diagnosis. Do we think that they had high blood pressure before they were diagnosed? Because I feel like when you're on the way to get diagnosed, when people are whittling down, you probably go through a whole bunch of tests.
Yeah.
So is it that there are no red flags going up for doctors because it's typically uh not as intense, or where's the actual gap?
Yeah, I think because we are in such a great place in treating MS that we've become hyper focused on the treatment of MS. And that's a good place to be. The fact that we have 20 different MS medications and it can take me a full hour to talk through that decision making process and all of the aspects of that care with a new diagnosed MS patient, but it does make us very focused on that, right? And so as a specialty, I think there's room to improve and grow to say, okay, first things first, you came in with weakness or blindness. We had to focus on what's causing this. Okay, it's MS. Like, and obviously, sometimes you're not going to catch every disease that someone has when you're hyper focused on that. And you have a new MS. It's really important to get on treatment as soon as we can. That's important focus and reasonable focus. But then once you get past that step, I think the gap is that we really can take a broader focus on the patient's health, and maybe you know, there's lots of places that are starting comprehensive care visits, which often means having a social worker and a physical therapist, an occupational therapist, or speech therapist all seeing the patient. But then, as part of those comprehensive care conversations or a part of just a wellness visit, okay, you're on your MS med. Now we want to look at your kind of global health. Screening for these other diseases is probably important. I think in medicine, often it becomes that, well, that's not my specialty, right? I don't know how to treat diabetes. I don't know how to treat hypertension. That should be their primary care doctor. But if patients don't have primary care doctors, are we actually asking, do you have a primary care doctor who's doing the screening at least? Or just because we're not necessarily going to be the ones driving the treatment, should we be playing a role in actually screening patients and then being like, hey, you screened positive for
Mhm.
high blood pressure, possible high blood pressure or diabetes or things like that. Let's make sure I'm going to hand you off directly to a primary care doctor at our institution and make sure that you're getting the care for that you need. I think that's the gap and the really high opportunity for improvement.
Are you finding that patients, when they are diagnosed with hypertension, are they better able to keep the hypertension under control? Is there a difference? Does the hypertension get better? Or are the patients with kind of the worst multiple sclerosis outcome also maybe correlating with mm, um, a certain type of adherence to treatment?
Yeah. Um, so my work has not specifically looked at that. So it's in terms of asking me about the research that I presented here at CMSC or our previously published works, it doesn't specifically look at that. But there are groups who have looked at hypertension control and found some different results. So in some large studies, just looking at overall health, they actually did not find necessarily worse hypertension control in MS patients. They found similar um, uh, results in a recent study. I think it was in the journal MSARD, multiple sclerosis and related disorders. They actually looked at disparities in hypertension control in MS patients, and that study, and I wasn't an author there, and so I apologize if I misquote a little bit, but I believe what they found was that Black Americans with MS actually had higher and high blood pressure, MS and high blood pressure, had higher rates of being prescribed a medication, but still had worse control of their medication. And so that could point to either an adherence difficulty, being able to stay on medication, or it could actually just mean that it's harder to control those individuals' high blood pressure, which is something that we've seen in the broader US population. And the exact reasons we don't know, could be epigenetics, could be environmental, right? If you live in an area with higher air pollution and things like that, you might be more likely to have uncontrolled high blood pressure. So there may be environmental factors and things like
Mhm.
that as well.
Yeah. So I want to get back on track to
Yeah.
your presentation. What are some of the key insights that we maybe haven't covered yet
Yeah.
from your talk?
So I think the closing kind of arguments, the highlights is high blood pressure is a very common problem in people with MS. A majority of the patients that we saw actually could meet American Heart Association diagnostic criteria for high blood pressure. A majority of MS patients who have high blood pressure don't know it. And so there is a big care gap in addressing high blood pressure in patients with MS. And then, if a clinic or provider is specifically looking at who should I be really focusing on, they should focus on women. They should focus on young people, and they should focus on people who have um, borderline blood pressures. And that's not to say that they should ignore and not say anything about someone who doesn't meet those demographics, right? We want to care for everybody, but this research is saying that if you are seeing someone in your MS clinic and their blood pressures are in the 130s, they're less likely to have already been told that they have high blood pressure by their primary care doctor than if you see someone who's always in the 140s, 150s, 160s, right? And so you might want to say something, even though it doesn't look that concerning in that particular clinic day, that like, oh, blood pressure 130 today, it's not the end of the world. Hey, your blood pressures have been 130, 135 for 3 or 4 visits now. Have you ever talked to your primary care doctor about high blood pressure? Or women, do you have a primary care doctor that you're seeing? Have you talked about high blood pressure? Young people, do you have a primary care doctor? Because they might not, right? And so a cue-in of like, hey, is this person really already know that they have high blood pressure or not, I think is an important thing to ask ourselves. And then the other thing that we looked at in our study as some pertinent negatives that things. So one of our concerns was race, ethnicity, insurance status. We did not find that those were actually associated with worse hypertension unawareness. And then we also looked at 2 MS drug classes, teriflunomide and S1P inhibitors, that are known to cause high blood pressure. And I thought, maybe being on those drugs might actually affect how aware or unaware you are of high blood pressure, because if it's caused by an MS drug, the PCP might not be catching it as much. But in reality, that was not associated. So I don't think MS providers have to be worried about which drug they're prescribing in terms of awareness of high blood pressure and diagnosing it. They should be aware that those drug classes do cause high blood pressure, but I don't think there's extra concern based upon our study. I think more research is needed in terms of whether or not being aware of your high blood pressure affects the relationship between high blood pressure and disability. We did not have the power to look at that. We looked at 2 outcomes related to MS inflammation, serum neurofilament light chain, and then we looked at 25-foot walk. But much of our database, it does include the pandemic time period where we're looking at. So virtual visits were a thing, and so we don't have a lot of time 25-foot walks, and so the numbers are lower. We did not find a significant association between hypertension unawareness and those measures. So it might be that hypertension awareness does not directly affect disability, or we might just not have been able to find that. And so I think larger studies and maybe prospective studies looking at hypertension control levels in MS will be important.
Awesome. Um, any last thoughts on this or MS in general, or even health disparities in general?
Um, well, I said in health disparities and in hypertension in MS specifically, I think the take home message is that these are not fixed problems that have no solution. These are things that have actionable items and solutions. And specifically when it comes to our research and high blood pressure and comorbidities, I think MS providers and MS comprehensive care clinics can play a significant role in helping make sure that their patients know everything they need to do to be healthy, not just talking about the pharmacology of DMTs.
Perfect. Thank you so much for joining us on MD Newsline.
Thank you for having me.
It's been a pleasure.